Now, in an opinion piece written by researcher Lisa Vetten, she details how the Department of Health intended to address domestic violence at one point, and how in 2022, when South Africa continues to have a few successful prosecutions and convictions in domestic violence cases, this could be the right time to use the vision the department had in dealing with domestic violence. Now, Lisa Vetten joins us now to give a fuller picture of the plan that was. Lisa, very good evening to you. Thank you for your time. You say the timing couldn't be more perfect when it comes to rolling out the pages of the primary health care package for South Africa. What does it contain?
Well, that package, which was first released in 2000, had a set of really simple ideas. It was to encourage nurses to ask women who displayed particular symptoms like headaches that wouldn't go away or even with injuries, to ask them about their home lives. Were they happy at home? How were things going at home? And the same with when they encountered children who weren't thriving. Was also inquire in a very diplomatic way about home circumstances. To then give, if they picked up domestic violence, to then give women information about shelters, about protection orders, and about where they could go for further help. So the idea was to give women a simple and accessible gateway to other referrals and to other important services, but also by asking, show that it was acceptable to talk about domestic violence, and that a health sector, a clinic, a facility, was a place where you could go in order to seek help.
And yet, as we hear of more and more cases and we see community members now taking matters into their own hands and people desperately going to social media platforms so that their cases can be escalated, for the cases to trend, for police to do something about it, and perhaps now, do you think that the public pressure could have some form of impact in allowing government to now scrutinize what is contained in these documents to implement it so that we see less and less of these cases?
Exactly, and I think why this is also a really important point is that the Domestic Violence Act, which the President signed at the end of January, is due to come into operation soon, and it has a provision that says the Director General of Health must provide guidance around the kinds of services the health sector should provide. So this is a really good opportunity to kickstart that process that was abandoned 20 years ago and get that going again. Because the health sector is a really overlooked source of assistance for women. Many women do not go to the police, but they do go to the clinic and they do go to the hospital. So here's a place where nurses and doctors could pick up if there's a problem and put women in touch with services or refer them to shelters when they are very seriously injured and really need to be able to get away immediately. So this is really an opportunity, and it's a challenge to the Department of Health and to government more broadly to take it on. I mean, we can't just keep on recycling court and policing options. They're obviously not making the difference we want. So I think to bring the health sector in would be the first genuinely new idea that we would have had in a good decade or more.
And of course, I think it brings to mind the reasons why you think the health sector doesn't respond to domestic violence in the same way that it would, for instance, respond to rape cases.
There's been a lot of pressure and a lot of focus on rape. So you've had the Tutuzela care centre that was set up in order to gather the necessary forensic evidence, provide good and compassionate care. But we've just never seen the same kind of public pressure when it comes to domestic violence. Part of that is because we do have this reputation as a rape capital of the world, and we have these very high statistics from the police. But we have no figures for domestic violence. You know, one of the things in South Africa is that it seems like you need a shocking statistic before anybody takes action. And the fact that there isn't a shocking statistic doesn't mean that domestic violence is not a problem. The research that we've done has actually shown us the violence that women experience most frequently, more often actually, in fact, than rape. But it's just never had the attention that it should have. And I think it's also because, you know, the healthcare sector, it was first overwhelmed by HIV. Now it's been hit by COVID. So I think what they've also tried to do is manage and try to keep out as much as they can. They've also never been trained. They've never been given guidance around what they should be doing. And I think there's also a certain level of discomfort around asking what can feel like personal questions. And also the fact that if somebody says to you, this is what is happening to me, where do they refer them to? Because there's no point in asking people to tell you about things that are painful and difficult if you can't help them and you can't refer them. So I think if we're going to make this work for the health sector, we've got to look at how do we link all kinds of different services together in order to make the health sector an effective intervention into domestic violence.
Studies have also shown that many nurses themselves have experienced domestic violence, which I suppose would be part of the problem when it comes to discomfort around speaking to patients about it. And also considering what really happens in a hospital. There are a lot of high workloads that doctors and nurses struggle with, and you know, that could also be a massive factor. What are the solutions around that?
I think it's firstly to ensure that, to make this work, it's make sure that tired and burnt out doctors and nurses don't become yet another source of secondary victimization. We need to target and locate the intervention very carefully. So I think paramedics, for instance, who are often the first responders at a scene, they'd be a good point of intervention to be able to ask women, you know, as they're driving them to hospital, what's happened? How else can I help you? Here else is where you can get help. I think to locate this in antenatal services, because we do know that there are quite a close relationship between pregnancy and often an increase in violence at that point in time. I think we've also got to look at casualty. At a minimum, if we can just encourage doctors and nurses, if we train them to ask a few questions and then to have the materials on hand so they can say, here's where you can go. And to also create those linkages within the hospital so that they can refer to social workers in the hospital or psychologists in the hospital, but so they don't feel they have to do everything, but they could be linked into other services who can take over as soon as they've identified that this woman has been injured. You know, I think in COVID, we would have had so much better information about the experiences of women being beaten if hospitals had been collecting information about why women were coming in for them to be treated. Because at this point in time, there's no obligation on casualty doctor to ask, who hit you? All they have to do is treat, and that's it. And it really is time that they learn to ask very diplomatically, how did this happen? Who hurt you? There's help available, and this is where you can get it from. So I think if we target it quite selectively in particular clinics and in casualty, that's one way to ensure the health sector doesn't get overwhelmed. And if we also provide the necessary training, including if we start training doctors and nurses now who are still at university, so that by the time they come, they're already being prepared to do this.
Very well. Thank you so much, Lisa. Let's leave it there for now. Some insight there from Lisa Vetten, a research and project consultant at the Faculty of Humanities at the University of Johannesburg's Gendered Violence and Urban Transformation in India and South Africa.